please, is going to be interactive at some point, so just be ready to join in. So for people who have been with us, you may have seen me draw this and you may have joined the previous one, so this will be a revision for you. For the visual pathway, I usually start with the eyes. Let me draw. I'm not very good with drawing. Let me draw something small. So that should be fine, and that should be okay. So this is what we call the eyeball or the eyes. And we usually will just draw something like that. And something, no, that's not good. Okay, so I'm just going to draw that inward and outward. Okay, and we'll draw that one like that, and then we'll draw, I think I'll make it bigger, and then I'll draw that one. So you don't need to draw this in your exam, so this is all for illustration purpose and to make it a bit clearer. I'm just going to change the color to black. Black. Okay, so this is where everything starts, and this is where I'm just going to start to make the rules clear. So that's the visual field. This is the nasal, temporal. Now, the rules, if you follow the rules, you are good to go. There are just about 3 rules to follow. Rule 1, the left supplies the left. Left supplies left. That's rule 1. Rule 2, the right supplies the right. And rule 3, at the socket or at the eyeball, so I'll just write at the socket, the opposite is the case. These are the 3 rules you need to follow. Anything below the eye socket, let me just put the rules separate. Anything below the eye socket, the rules is left supplies left and right supplies right. But once it gets to the eye socket and around the visual field, it changes. The left actually will supply the right, and the right will supply the left. Who doesn't understand these rules before we start to draw? Anybody confused?
What do you mean by eye socket?
Yeah, so this is it. These things I've just put here are the sockets. Or some people will draw their just below like that and paint it like that. So anything that gets above that dark line, the rules will change. Does that make sense? The person that asked about the eye socket, do you now know where the eye socket is?
Yes.
So anything above that eye socket, the rules change. Okay, so let's now play with what we've said. Let's play with the rules. So I'm going to use different colors. So what I want to do now is to draw the pathway, and I'll start with the eye socket and draw down towards the nerve. So this one, you can see the color. It's moving here. This is the left. Let me label this properly. So back here. So this is the left side, and this is the right side. Okay. So following our rules, if you see what has happened, the left below the eye socket has stayed on the left side. That's what it has done. So this is all on the left side. Now let's move another one away from the left. So this one is going to move from the left. But remember that even if it's going to the other side, it needs to stay on the left side. So it will stay on this side. Does it make sense to everybody? Anything moving from the left stays on the left side. Is it easy for everybody?
Yes.
Who's confused?
Yes.
Okay, nobody. Right. Let's do the right side since it's easy. So these guys are moving from the right. So just following what we've just done, there will be one pathway moving towards the right, and the other one has to go to the right. So pardon my poor diagram. Let me just make it a bit better. Okay, so let's redraw that. Okay, and this is, oh, that's too big, too broad. Okay, so that one stays here, and this one will go on here, and then the blue one will go on that side, and this one will go on that side. Okay. Yeah, so is it clear now to everybody? Does this make sense? Left, left, right, right.
Yes.
Anybody confused at this point? Nobody. Okay. Now, once we get to the eye socket, remember the rules change. Let's change the color to red. Done. So this guy, rather than stay on its side, which is the left, it goes to the other side. So this guy will actually go to the opposite side. So from the left, it will go to the right, and this guy will go to the opposite side. From the right, it will go to the left. And the same thing, this guy goes here, and this guy goes here, following rule 3. Rule 3 says once it gets to the socket, it goes to the opposite side. It doesn't stay on the same side. So the pathway on the right will go to the left, which is the nasal part, and vice versa. Does everybody understand this? Who's struggling with this? No. Okay. So having understood this and having drawn the pathway, we need to be able to understand where can the lesions be? Where can my problems be? And so that's the next set of stuff I'll be drawing. I'll just use a blue to draw that. So where can my lesions be? First of all, your lesion can be at A. So what is A? A is the retina. So I'm just going to label A here as the retina. Or your lesion can be at B. And what is B? B is the optic nerve. Optic nerve. Or your lesion can be at C. Here, cut here. And what is C? C is optic chiasm. Optic chiasm. Or my lesion can be at D. So what is D? D is your optic tract. So you need to know all these names, and they are not very difficult to know. Now let's talk about E, F, and G, which I didn't draw earlier, so that I do not confuse anybody. So now we can draw it since we know the main ones. So There's something here, this one, which I'll label shortly, is called the lateral geniculate nucleus. So it's not the eyes or whatever, it's called the lateral geniculate nucleus. And so what we'll usually do, let me draw my N. So I'll call this the macular area. And remember, we're just illustrating this so that it's easier for you. You don't need to draw it in the exam. So 1, 2, 3 lines. 1, 2, 3 lines. 1, 2, 3 lines. 1, 2, and 3 lines. Yes. Okay. So let's label the remaining parts. Let me change back to blue. So what are the names of all these new things I've just drawn? So this one is, I've shortened it, is LGN. LGN. And what's LGN? Lateral geniculate nucleus. So we call it, so we've done C, D, and we call LGN E. Now there's F here, and there's E here, and there's H. So what's F, G, and H? So I'm just going to go to a new board. Your F there is actually F, and let's put it F and E are your optic radiation. Optic radiation. And then your H is what we call the occipital cortex. And there can be lesions across board. So there can be a lesion at the retina, there can be a lesion at the optic nerve, there can be a lesion at the optic chiasm, there can be a lesion at the optic tract, there can be a lesion at the optic radiation, there can be a lesion at the lateral geniculate nucleus, there can be a lesion anywhere. So does this make sense so far to everybody? Who doesn't understand how these things came about, the names, everything? Who's confused about anything so far? Because we want to move to the real thing that they'll ask in the exam, the main question for your exam. Who doesn't understand how we got here so far? Anybody? Okay. If everybody understands, then we can play around with the main thing. So let me switch back to black, and I'll use the first one as an example. So lesion at B. Lesion at B. So a lesion at B, which is here, means that we've cut off this guy. Can you see me shade this guy? We're cutting him off, and we've cut off this guy I'm shading. Now, if we've cut off this guy, because this is on the right side, this guy, which supplies this place, has been cut off, and this guy, which supplies this place, has been cut off. It means this whole visual field has been cut off. Now, if you check the left side, this side where I've shaded, there's no lesion there. It means there's nothing wrong there. The kind of problem you will have if we draw the two eyeballs or the two visual fields is that this side will be affected because what is supplying this side has been cut off. And this side will also be affected because what's supplying this side has been cut off. So it means this whole right eyeball or this right vision has been affected in B. And for this to be affected, this man will have only one eyes to see. This one, he can't see from here because it's affected. This is what we call monoocular visual, it's 1O, monoocular visual loss. Now, because it's on the same side that is affected, you can see the lesion is on the right side and it's the right eye that is affected. We will call it an ipsilateral. Because if it was on the other side, we'll call it a contralateral. So lesion B will lead to an ipsilateral monoocular visual loss in your exam. Who does not get it? By the way, if you are still forgetting, B means there's a lesion at the optic nerve. The optic nerve has been affected. Imagine there's a cancer that's damaged the optic nerve. What will happen? It will cut supply to the visual field, the nasal and the temporal part, and it will lead to monoocular visual loss on the right. This is the right and this is the left. So this right eye is blind. The left eye can see. This is called monoocular visual loss. Is everybody happy?
Yes.
Okay. If everybody's happy, then we will go to C. So for C, at this middle, which is the optic chiasm, there's a lesion there, growing there, and that lesion has cut supply. Now, one of you is going to tell me where it has cut supply to. So I'm just going to draw the eyes, and I'll divide it into two, and I'll call this 1, 2, 1, 2. And this is the right, and this is the left. So yes, I'll give you about 1 minute to look through and see where the supply has been cut, and I'll call somebody, and the person will tell me the answer. I told you it was interactive, especially because the exam is coming through.
Why did this station cut? I didn't get that.
C. We're on C. The optic chiasm is cut the middle here. C. Okay, well done. Let's have who's going to help us now? Joy. What's the answer?
So the lesion is in the optic chiasm.
Yes, optic
So
chiasm. Just tell me if you can say left one will be gone, or left 1 and 2 will be gone, because I made it easy for you.
Left 2 will be gone. Dark.
Left 2 will be gone. So let me shade it out. Left 2 will be gone.
And right 1 will be gone.
And right 1 will be gone. Does everybody agree?
No.
No, the opposite.
I don't even agree
The
myself. Wait. So this is Joy. Let's put another person C. Dr. Sanusi, what did you draw? Dr. Sanusi around? Yeah, Dr. Sanusi is not.
Hello, can you hear me?
Yeah. Oh yes, I can hear you now. Yes. Dr. Sanusi, what did you? What was affected?
Yeah, I think the one on the left and 2 on the right.
1 on the left. Let me do 1 on the left. Are you guessing, or are you sure?
No, I think it's bitemporal.
No. I don't need the name.
Okay.
The part that is affected. Are you guessing, or are you sure?
Yeah, I'm sure, because if there's lesion on that, the lesion on that, then it's the nerve coming from that side. Yeah, it's 1
sure.
and 2.
Okay, so let's go and look up now. So 1, 2. Let's go and see who is correct. This is Dr. Sanusi. All right. So let's trace it. Dr. Sanusi and Dr. Joy. So if something is cut in the middle, see this one? Can you see me shade? Joy, can you see?
Yeah.
Oh,
is not
shit.
affected.
Yeah.
This one is not affected. Can you see?
Mm.
So if this is not affected, it means this place is not affected. This side is not affected. There's nothing wrong here. Okay, so that's gone. And this one too, can you see me draw balls on it?
Yeah.
It's not affected. It's gone past because there's no lesion there. And it ends here. It ends here. So it means these two are not affected. It's looking like the outer ones are affected, but we need to check. So let's draw some balls on this one. And it's going and it's going, and it meets a blockade. Oh my God, it's a lesion. It can't pass. This is affected. Nothing is delivered to this side. Nothing gets here. It means this side is affected. Does it make sense, Joy?
Yeah, it's the other way around. I forgot that it was reflecting on the visual field. Yeah.
Correct. Yes. So again, this guy is trying to go. He's trying to go. It meets an obstruction. It can't go any further. It tells the owner, I cannot move. It means this side will not get power. So this side is affected. So the outer parts are affected. So if we're following the outer, this will not be correct. This will be correct. Now, the next thing is you need to be able to name it. Some people will know this in the exam. Let's take out the names. So some people will know this in the exam, but then in the exam is the name they will put. So remember, we call this monoocular, one eye. Mono, one eye is affected. Now, what do we call if half of the lateral sides are affected? What do we call that? Dr. Sanusi, you were about telling me the name.
Hemianopia.
It's called a hemianopia. I agree. But for completeness sake, Dr. Sanusi, what type of hemianopia will we call this? Is it monoocular like I did for my own? I said mono, one eye. Or
no,
what?
It's not monocular.
Okay, so tell me, what is it?
That would be like binocular.
Yeah, so who knows what binocular will be called? Because it's affecting one side.
Bitemporal.
It's affecting the temporal side.
Bitemporal, yeah. So
this is called bitemporal hemianopia. Is it easy for everybody? Who failed it and still doesn't understand how we got bitemporal hemianopia? Anybody?
Can you go back?
Yes,
up?
please. Yes, I'll go back up, definitely. Yes.
Excuse me. So this so coming from, you said the lesion was at C, which is the optic chiasm. So this whatever you drew that was coming up. So you said left goes to left.
So let's follow the rules. I didn't say left goes to left.
Left
I said
left.
I said below the socket, and this is the socket. So socket. So anything above the socket follows rule 3. But anything below the socket follows rule 1 and 2. So left supplies the left below the socket, and right supplies the right below the socket. When we get above the socket, where the visual field is the other way around. The opposite is the case. Anything that gets to the left will go to the right, and anything that gets to the right will go to the left. Does it make sense?
It does. So
is that where you had the problem?
I just want to understand it better. So if this left,
let's understand it better. Let's draw it again. You're going to help me. So these are Dr. Ola's eyes. Of course, they are very small, and we need to draw that out. So I'll just draw that out, and then draw this one, and draw this one. So that's the lateral geniculate body, right? So I'll draw the socket. This is one socket, and this is another. This is one socket. This is another. So I want to draw this from the left, the first socket here. So imagine there are 2 sockets each. There have to be 2 from the geniculate. So the first one wants to go. Where will it go? Direct me.
It's
Yes,
going to the
Jennifer.
left. It's going to the socket.
Yes, it needs to go somewhere. It's a wire. It needs to go somewhere. Where will it go? Ask them where to go.
It's going up because it continue to the left. But
To the left.
When you get
Okay.
to this, no, yeah,
Like this.
when you get to the
Yes.
socket,
And
you
where
go
should I
to the right.
I should go like this.
Yes.
No. So you go like this. Get to the socket first on the left.
Okay.
Once you get to the socket on the left, the arrow now goes right
Goes right
to the visual field. Remember, there's a visual field up. This is what the person is seeing. So whatever the person is seeing here goes to this side.
Okay.
And whatever the person is seeing here goes to this side. Okay, does it make sense?
Yes, it does.
Let's draw this one again. Tell me, where does it go?
So that one goes to the right.
To the other eyes, okay?
Yes.
And when it goes to the right, does it go to the left part of the right, which is the nasal? Or does it go to the right part of the right, which is the temporal? Where will it go? So I've gotten to the right, but where? Left or right?
It's also right.
No. Left stays with left. Remember our rule.
Oh, on
right
the left,
stays
sorry.
with right.
Going to the left, yes.
So anything on this left side has to stay on the left. So it will stay here. And anything on this right side has to stay on the right. So this is right. This is right. No wonder they came from the right. Who doesn't understand? If you don't understand, we can go again. Don't worry about that it's just you that doesn't understand. It's better it's just you that doesn't understand, and then you understand it today, than you leave here without understanding. Anybody wants to go? If you want to go, I will draw it for you. Anybody? Okay, that's fine. Let's go back to our diagram. So we've got bitemporal hemianopia, we've got monocular lesion. Now, there's a lesion at D, and we know D is the optic tract. Dr. Loretta.
Yes, Dr. Ola.
So everybody should draw it, remember, but Dr. Loretta is going to guide us. So Dr. Loretta, when you are ready, you tell me what defect this gentleman has. 1, 2, 1, 2. Remembering that this side is the left and this side is the right. The defect is at D, and D is optic tract.
So on the left.
No rush. Are you ready? Are you sure you're ready?
I think I'm ready.
Okay. Go if you're ready.
So on the left, it will be the temporal. So that would be 1.
Okay.
And on the right, it will be on the nasal.
On the right, to be on the where?
On the nasal. So that would be
Here.
1 as well. Yeah.
1. Remember, I'm not the one that will say you are right or wrong. It's the other candidate. So I'm not going to mark your exam. Your friends will mark it for you. Right. Is she correct or is she wrong?
Correct.
It's correct.
Everybody got this. Okay. Who did not get it? If you didn't get it or you are not sure how this happened, just let me know. Loretta will take you through. Anybody?
I'm not sure, please. I'll just like to see the diagram.
Yes, Loretta, please take her through. So let's draw it for who's not sure. What's your name? Sorry.
Abbas.
Oh, Dr. Abbas, yes. So let's draw something a bit sketchy. Okay, so the lesion is here, Dr. Abbas. Okay, so it means that the two that will live here will not pass. Am I correct?
Yes.
Okay. Now, where are these two going? That's where we need to know. So, Dr. Abbas, help me. This first one, where is it going? Where was it originally going to before it was blocked?
So it was going to the left.
So this is the right, and this is the left arm.
Okay, so it was going to the right.
It was going to the right. And was it going to the right, or was it going to the left? So this is left, right, and this is right, right. Where was it going to?
It's going to the right, right.
Yeah, it's going to the right, right. Okay. And where is this one going to? This other guy?
It's going to the left.
Is it left, or left, right?
It's going to the left, left.
No, so remember that right will only go to the right. It has no business with the left. Rule 1. Let's go back to the rule. Left supplies left and right supplies right. Does it make sense, Dr. Abbas?
Yes, it does.
This is where the problem came from, I'm sure. So where will it go now? Right. From here, where will it end up?
It will end up on the right.
Right, which is here.
Yeah.
On the left of the right, so left, right. Okay. Does it make sense, Dr. Abbas, so far?
Yes, it does.
But now that there's a cut, so it means that this guy will not have power and this guy will not have power. But where was this guy originally supplying and where was this guy originally supplying? So let's clean this one and put our visual field so that we'll know where it was supplying. So this is temporal, nasal, temporal. Okay, so where was this guy supplying? This guy I'm shading. The first cutoff. Sorry, say it again.
Temporal.
Nope. So this now follows rule 3.
Oh,
so if you don't go with the rules, it won't work. So anything above the socket, can you see where the socket is? Can you see the socket? Follows rule 3. It is opposite of rule 1 and 2. So anything on this side will go to this side, and anything on this side will go to this side. Does it make sense?
Yes,
so it will go to the opposite side above the socket. Does it make sense?
Yes, it does.
Let's go back. So where would this go now?
So it will now cross to the nasal side.
Exactly. And the nasal side is the opposite side, which is right will go to left. So this side will be blind because signal was cut off. Okay.
Yeah.
And this guy, where will he go?
It will go to the temporal, the opposite side.
Temporal, excellent. Because the signal was cut off, this guy will be blind on this side. So if we are drawing our 2 eyes and you do it like that, you will shade this side.
Yeah.
And you will shade this side. Does it make sense?
Yes, it does. Thank you.
Okay. Now we need to know what name this is. So who answered the question was Loretta. Remember, the hardest thing now is to name them. Loretta, what's the name?
Heteronymous. Hemianopia.
So hetero. Why hetero? Where did we get hetero from?
I was thinking because it's not on the same side. Like one is on the nasal and the other is on the temporal.
So if it's not, so if that's what you're trying to say, you're saying if it's on the opposite side, we're saying contralateral and ipsilateral. That's what we'll use.
Okay. So it should be ipsilateral.
First of all, let's start with the basic.
Okay.
Is this a hemianopia or monocle? What type of? Let's start with the basic. It's a hemianopia. Okay, because it's one side. Hemi diaphragm. Hemi one side. Hemianopia. This is the eye to see. Anopia. Hemi one side. Okay, that's the first thing. Now, this hemianopia, what would you say? Would you say it is bitemporal or will you say it's homonymous?
It's probably, I think what you had said before, ipsilateral, because it's on the same.
Yeah, before. So ipsilateral is the last thing we'll deal with. But is it on the same side? So this is what we call homonymous because of how it is. So I see what you're saying. So contralateral will be where is it on the side of the lesion? That's what I meant by contralateral. Sorry. So if I've confused you. But don't worry too much about ipsilateral or contralateral first. Know the kind of lesions first. So this is going to be a homonymous hemianopia. So this one is on the temporal side, but this one is on the same side. We call it homonymous hemianopia. And because of where the lesion is on this side, and the problem, so the lesion is on the right side. Where are the problems? They are on the left side. Can you see? Left. But the lesion is on the right. This is where contralateral comes in. So someone will say this is a contralateral homonymous hemianopia. It's a full name, but whether you get this contralateral or not, know the homonymous first. Know the hemianopia first. Does it make sense?
Yes, thank you.
Yes. So this contralateral and ipsilateral comes from where the lesion is. Is the defect on the same side as the lesion or not? That's where we get this name from, contralateral or ipsilateral. Ipsilateral, same side. Contralateral, away, other side. Does it make sense?
Yes. Thank you.
Who is struggling with where we are at the moment because we want to move further? Anybody? Okay. Now, let's go back to our diagram. So we've done B, C, D. Now we're going to do F, E, H. Now, F and E, remember that is the optic radiation. F, E are optic radiation. But this is just one part of it, and E is another part of it. It does mean that if it appears on a visual field, if F appears on a visual field, it won't appear full because it's just one part of it. So if it was supposed to appear like this on one side, it will appear like this because E is the other part. So this will be E, this will be F. Does it make sense to everybody? Who's struggling with what I've just said? This whole thing, the 6 strands, is your optic radiation. But if you see it, it's been broken down into 2 sides. One side is where we have labeled F, and the other side has been labeled E. Sorry, let's label this one E, and let's turn this G. So this is going to be G, sorry. So one side has been labeled F, and the other side has been labeled G. So for us to get a full side, F and G must be added together. Does it make sense to everybody? Okay, we'll find out. Everybody's quiet, so we don't know whether it does make sense or not. So let's look at a lesion at F. For example, F. So let's put F here. Dr. Osita, lesion at F. Tell us, what should we expect? One, two, left, right. Yeah, Dr. Osita. Oh, you're on transit. Okay, let's have someone else. Dr. Emmanuel, lesion at F.
So I think it will follow the same pattern as let me scroll up, let me see. I think it will follow the same pattern as D.
Correct. But excellent. It will follow the same pattern as D because it's on that same part and it has been cut off. Look at D has been cut off there. So F will follow this tract as well. But it's only one that is going. So E will go, but F will not go because F has been cut off. So how do we then do this if it's following the same pattern as D?
Then it will be, I don't know if it will be the upper or lower part.
1, 2. Yeah, okay. So yes, no, that's fine. So remember, okay, I see what you are, I see where your confusion may be. So this one that is G is the upper part, and this F will be your lower part. So the one inside is the upper part, the one outside is the lower part, and it's the same thing on the other side, vice versa. Okay, so now you can go.
Dr. Ola, can we also, is it also called superior and inferior?
Yes, and well, you are calling the name before the time. It's supposed to.
Oh, okay, sorry.
That's his job. He's supposed to tell us where the lesion is and tell us the name, but you've called out the name. Anyways, tell us where the lesion is, Emmanuel.
So, the lesion is on the left.
So you are doing F.
Yeah, F.
Yeah,
and F is lower. Okay. So the lesion is on the left one will be 1, but it will be
so 1 upper, 1 lower.
1
1 superior,
lower.
1 inferior.
1 inferior.
Remember that. Yes. So remember that F is inferior. So 1 inferior. So that will be this place shaded. And the other one?
Right to be 1 inferior as well.
1 inferior. Excellent. Who doesn't understand? Okay, name it. Now that you've gotten where the lesion is.
So because it's
if it doesn't get the if a circle is half like this, let me clean it. If a circle is half, it's called hemi. But if a circle is quarter, called a quadrant. Okay, name it now that you know what these things are.
So it's homonymous quadrantanopia.
So it's a type of quadrantanopia. Yes, so this is, but instead of homonymous, you told me that this is inferior. Why don't we give it a better name?
So inferior homonymous quadrantanopia.
Inferior quadrantanopia, or some people do it as quadrantopia. Anyone you like. Inferior quadrantanopia. It's N there, quadrantanopia. Now, would you say this is contralateral or ipsilateral? Knowing where the lesion is. The lesion is on the right. Ipsilateral or contralateral?
It's still contralateral.
It's contralateral. Contralateral. So that's it. Contralateral inferior quadrantanopia. Is it easy?
Yes.
Okay. Dr. Morolake, if the lesion was in E, so not E, let's see, it's G. We've changed it to G. What will it be then?
Contralateral superior contra.
No, 1, 2 first. 1, 2. Help me label it.
So the blindness is going to be on the upper parts of
superior part of where? 1 or 2?
1.
Okay, so here, is this what you mean? Yeah, thank you. Let me shade it off quickly for you. I like doing the kindergarten work while you do the hard work. Okay, and this one? 1 or 2?
1.
1 as well. Okay.
Yes, and the upper part.
Is everybody happy with this? Okay, name it then.
Contralateral superior quadrantanopia.
Contralateral superior quadrantanopia. Okay. Now, there is one more lesion we need to talk about, the lesion at H. Remember that H is the occipital cortex. This is where we call, I've labeled here, occipital cortex.
Dr. Ola, sorry, can I?
Yes.
Can I just take you back a little bit? Please?
Why not? Why not?
I'm just trying to say how we represented which one would be the upper and which one would be the lower. Is it based on how you divided?
It's based on how it goes in the tract, right? And how it goes in the tract, the visual tract, is that these straight ones that doesn't need to curve is usually on, if it's on the right side, is usually the upper. It will be the opposite on this side. So have you heard of what we call PITS? Who knows the acronym PITS?
Parietal inferior, temporal superior.
So this is in this area that these things come into play. So this one will affect the upper part, and this part will affect the lower part. Now for this one, I'll just say it's easy to just learn it that this one is upper and this one is lower, so that you don't have to worry too much, and it's not a lot of cramming. Since you understand the remaining, you can just learn this as upper and this will end up as lower. Does it make sense?
Yeah, so
instead of trying to understand the pathophysiology of how the tract runs from the radiation area. Yes, go ahead.
Okay, sorry, so let me just use that upper as an example. So if you're tracing it all the way past the socket to so let's say the affectation was at the upper, because I'm just trying to like picture how it was quadrant.
So it will be the same as D. Any of them. Both F and G is the same as D, because just think about it being cut at the level of E is the same thing. Think of it being cut at the level of D, it will end up being the same thing. So whatever you are supposed to get in D is what you will get in G and F. It's just that imagine that there are two strings. G is one string and F is another string, and both strings make up a homonymous hemi. It makes one side. So if one string is absent, it can't make up a whole full side. It will make up only half of it, which is a quadrant. Does it make sense?
Yes, it does. Thank you.
Okay. Right. Let's go to the last one, the last most important one. There are some other things there, but the last most important one is the occipital cortex. And we have Taron, Dr. Taron.
Yes, yeah.
So if we are dealing with the occipital cortex, I'm going to draw. So what do you think will happen here in the occipital cortex? Knowing that the occipital cortex is this part and is divided into two. So we're dealing with the right side of occipital cortex, which is H. Our drawing is a bit messy because we've shaded around it. But try and imagine where it's going to pass through. What do you think?
On the right side or left side? Are you asking?
On the right side. Everything we are doing today, all our lesions are on the right side.
Okay, all right. So it would be on your diagram.
If there's something that if I hear, I'll be very happy, Dr. Taron.
So on the left side, the first circle, the first half, macular spiral.
Sorry, say that again.
So do you want me to say where the loss of vision would be? Yeah.
So this is 1, 2, 1, 2.
Yeah.
This is left, right.
Fine.
Go again. Tell me.
Fine. So on the left side, 1. If you could.
On the left side, 1. Excellent, Dr. Taron. Well done.
But
let me shade the left side. Oh, is it everything or a quadrant, Dr. Taron? Everything.
It's just a small piece in the center that would be missing.
Yeah, so we'll shade everything. Yes. I'll come to what you're saying, Dr. Taron. Yes. Okay.
Yeah.
And on the right side,
it's again what number 1?
Is it number 1 or number 2, Dr. Taron?
It would be number 1.
Let's go. Yes, number 1. What did other people get? 1 or 2?
1.
Good.
Got 1.
Right. So, what does this mean? It means that it's the same as which one? D.
Occipital cortex. Yeah.
Can you see?
Yeah.
Because it will only make sense that if it's passing through D and there's a lesion, it will act like D. Does it make sense to everybody that everything below D will act like D? Who doesn't understand what we've just done? Who's confused about why it looks like D? No. Now, there's something Dr. Taron was trying to tell us. Anytime it is at the occipital cortex, it will spare a small place in the middle called the macula. This is where they ask exam question. So anytime it's occipital cortex, there is what we call macular sparing. And this is what they'll be looking for in your exam. So this will be in your exam a contralateral. Oh, sorry, Dr. Taron, tell us the name. Sorry, I was going to say it for you. So what's the name of this?
It's homonymous hemianopia.
So it's a homonymous hemianopia with
macular sparing.
Yes, macular sparing. Who can complete it? He has gotten it 95%. Contralateral. Who is struggling with visual field defect? Anybody? Okay. So in your exam, what can they ask me, Dr. Ola, in the exam? They can ask you about a lesion in B, C, D, E, F, G, H. Now, there's one we haven't done. A lesion at A. Remember, A is the retina. So who's going to answer this? Let me see. Dr. Makinde. The patient has a lesion on his retina. He's run to you and says, Doctor, I'm having some visual field defects. What kind of visual field defect will he suffer if it's at his retina?
So it will be monocular blindness or visual loss. This is at the retina.
Some people don't quite agree with you. At the retina, there's something else that happens. So let's do, this is A, but it's just the retina. Anybody else think something else? If the retina is affected, what kind of blindness will this patient present with? On the right. Damage on the right. Anybody knows what will happen?
Sorry, can you go up again to the...
Yes, I'll go up. This damage is already here. It's already on the eye. It's not, the pathway doesn't apply here. So what will happen?
Peripheral visual loss.
Yes. So how will it appear on his visual field? Is it peripheral or central?
I think you have like a tunneled vision.
Yes, so you have a scotoma. This patient is likely to have a scotoma in your exam. And the scotoma will be at the center. So if it's on the right, it will have... So the person that said peripheral visual loss. Yes, so this is what will happen. He will not be able to see the center because there's a scotoma. So he has to see from around. This place is blocked. This thing is called, in your exam, it's called a central scotoma. Okay, so now I'll just present to you, and it's going to be on the group, so not to worry too much about it.
Dr. Ola, sorry
yes.
to take you back. How is it a peripheral visual loss then?
Yeah, so it's not a peripheral visual loss, it's a central scotoma. That's why I was pointing it out to you.
Oh, okay, that's fine.
Yes, the person that says peripheral visual loss is going to be a central scotoma. That's what you should expect in your exam. So these are the things we've just talked about. When it's at the optic nerve, let me put a pen here so that it's easier. When it's at the optic nerve, only one eye, depending on which side, only one eye will be blind. So depending on whether it's the left or right. Okay. When it's at the chiasm, this is what we talked about.
Sorry, what's the first one you said? Sorry.
This is what we've just done. What we've done just now. I'm just showing you these pictures on your slide, the one that you'll be getting. So if it's at the optic nerve, depending on what side is cut off, then that's the side where you have the monoocular vision. The difference between what we've just done and your slide is that it has causes, which we've not talked about. So these are some of the things that can cause monoocular vision loss: Amaroxis purgat, optic atrophy, retrobulbar optic neuropathy, trauma, optic neuritis. These are causes of monoocular vision loss. So the same thing with the optic chiasm. Now with the optic chiasm, please note, this is where, remember I was talking about your bitemporal hemianopia. Please note that there is an optic chiasm lateral, different from the one we've just done. If you go back and try and look at only one side being affected, this is what you will get. But don't worry about this. They never ask this in the exam. We've just put that there for you to know. And so I've not worried too much about that. But this is the one that you should worry about in your exam. It's easy to trace. It's easy to understand. And remember, pituitary adenoma, likely one of the commonest things they'll ask in the exam. Same thing for the other lesions. These are the causes. Remember all the ones we talked about, the quadrants, the upper and lower, and all that, and the macular sparing. This is your diagram, and these are the pictures beside it. So if you have it cut out at A, B, C, D, E, F, G. So we just labeled the lateral geniculate nucleus, but of course the cutting is from the pathway from the lateral geniculate nucleus. So that's E or F. And remember, your E or F will give you a quadrantinopia depending on which one. And then remember that at your point here, which is where you have your macular sparing, same side. Okay. And this is where this one shows you where the lesions are. So there's an X there to show you where it is no longer being transmitted. Okay, so that will be on the group for you to play around with tonight and be ready for your exam. You shouldn't fail questions on visual pathway after we've revised it and made it so easy. Right, who is next to present? Admin, who's presenting next?
Sorry, Dr. Ola, can I just quickly ask,
yes,
there's some question whereby the structure in a way that maybe a patient with paralysis of one half of the body and then one of the vision,
the structure like in such a way that what?
Like a patient with, let's say, weakness of the arms and the legs and maybe some facial weakness thereabouts, like symptoms of stroke. And they're now having blurry vision on one of the eyes, because I know it's contralateral. Like sometimes, if for instance there's paralysis of, say, the right half of the body, and patient is now having blurring of vision on I don't know whether one of the eyes or something. I'm just trying to correlate the contralateral with the paralysis.
So you can't do that. In the exam, they will give you a bit more to work on.
Okay.
Yes. So if the patient has paralysis, it can be a MCA stroke, and an MCA stroke can come in both 4 and it can come in 5. You can see that 5 will give you a quadrantinopia and 4 will give you a hemianopia. So at the end of the day, they need to give you a bit more information, and in the AKT, they usually do. They will not leave you hanging. So yes, if you've seen questions that are incomplete, that can confuse you. But if in the AKT the questions are complete, you would know what you're dealing with. And candidates are always happy, especially if you know this. Candidates always get it very easily in the exam. Okay, cool. Any other question?